Good morning, everyone. Mark Crowther, Chair of the Department of Medicine at McMaster University. Welcome to the second Chair's Grand Rounds for 2021. Today, we've got two speakers. Just a reminder to everyone, this is the webinar function of Zoom. I'm sure that everybody by now is completely familiar with this, but you do not have open mics. If you wish to ask a question, please put it in the question and answer box, and I will address them. The chat function is disabled. So you cannot use the chat function. I do that just because it's impossible to track questions in the chat function. These rounds are being recorded and they will be available later on the Department of Medicine YouTube channel. If you want to find that, just go to that thing called Google and type McMaster Department of Medicine YouTube and you'll be directed directly to it. I'll also point out that earlier this week we had a special set of rounds on how to use McMaster's Office 365 implementation. And a really great set of rounds which could save every single person watching hours of their time if they use some of those tools that are freely available to you. Today we have a great set of rounds, very interesting. I was having, Karis was and I were chatting earlier that I'm having an existential crisis because I actually met Karis Massarella almost 40 years ago, which then reminded me that I am really, really, really decrepit because I can't believe that there's somebody still around who I work with on an almost, well, monthly basis at least, who I met almost 40 years ago, other than my wife. Karis Massarella is an emergency department physician and consultant in the area that we're talking about today, transgender care. And then Will Harper, who's the division director of endocrinology at McMaster. Many of you will have seen Will in his performance last night around the critical care triage system. Will's been doing incredible work in that area and all kinds of other stuff through COVID. In fact, both Karis and Will are kind of really frontline providers through the course of COVID. That will be the last time that COVID is going to be mentioned today. If anybody asks a question on COVID, I'm going to immediately silence their question. So without further ado, I'll turn it over to Will. I will, or Karis, I'm not sure who's talking first, and I will be moderating the questions. And at the end, hopefully we'll have time for some question and answers. Thanks very much.
Thank you, Mark. Thanks for that introduction. I'll be starting the talk. This is our disclosures. Dr. Massarella and I, neither of us have any financial or other non-financial relationships that would put us in conflict of interest. For today's talk, we will be, I'll specifically be talking, actually both of us will be talking about the off-label use of particularly hormonal medication for transgender care. And I do want to say that a select number of my slides have been adapted with permission from Dr. Raymond Fung. Dr. Raymond Fung is a Canadian expert in transgender care and working out of Toronto, and actually was presenting rounds at our Endocrine Citywide Metabolic Rounds last month. And just to put a plug in for that, we do our Endocrine Citywide Rounds every third Tuesday of the month at 8 a.m. and they are by Zoom during the pandemic. And we talk about all sorts of endocrinological topics and metabolic topics as well. So I encourage people to consider coming to those rounds as well. So our objectives for today, Karis and I would like to discuss endocrine care. I'm going to focus on the endocrine care for transgender people, specifically looking at contemporary affirmation models versus the old psychiatric-based models. We'll also be talking about general medical care of transgender people as well. And then we'll be talking about gender identity in present-day culture and its implications with respects to equity, diversity, and inclusivity. Today's rounds are actually part of a series that Dr. Anand has endorsed for the Chair's Grand Rounds, looking at various EDI issues. Last month, Dr. Verhovsik, as we know, presented on anti-racism as it pertains to Black individuals as well as Indigenous individuals. Today's talk, we'll be looking at transgender people, and we have another talk, I think, coming up next month as well. And then finally, I will talk a little bit about decision-making in uncertainty, because it's an area of expertise that is an interest of mine. I think it's important that we start with some terminology, because I think a lot of the stuff we'll be discussing today is not necessarily familiar to people who don't work in the area of transgender care. So I'm just going to go through some of these definitions because I think it's important for people to understand what it is we're talking about. So natal sex is the sex that people are assigned at birth and is usually designated on the basis of external genitalia, sometimes chromosomal analysis. And this is to be in contrast to gender identity, which is more of an innate sense of feeling male or female, or neither, or some combination along that spectrum in terms of not necessarily being dimorphic or in an androgynous zone on the spectrum of biological and culture-based determinations of sex. Gender expression is how someone presents to the outside world their gender through clothing, hairstyle, voice, behaviors, etc. A trans man is a person who was born natally female but then transitioned to male. A trans woman is someone born natally male and transitioned to female. But terms like FTM or MTF are really, we're moving away from such terminology and just simply stating trans man or trans woman to distinguish from cisgender, which are people who have their natal sex congruent with their gender identity and gender expression. All of these things are completely separate from sexual orientation, which really just refers to whom someone is sexually attracted to. And it was also in contrast to intersex. Intersex are a group of different conditions and people that are born with variations in their chromosomes, gonads, and sexual hormones, often leading to ambiguous genitalia at birth, making it difficult for assignment of natal sex. And this is something my pediatric colleagues are expert on and are called to help out, and is a clear biological separation with respects to the concepts of dimorphism for male-female sexual category. So that's once you understand that terminology, then it becomes a little bit easier to understand this controversy, I think, that has come by in the context of gender identity. Initially, this all probably stems from this question or concept that a lot of people have, is that sex is biological and is always dimorphic with a simple male-female categorization. And in truth, that is simply not true. Anyone who's worked in the field of endocrinology knows that at least, if not 1 in 50 births, people do not have a clear biologically sex determination. Intersex is present in 1.7% of births. The most common cause is congenital adrenal hyperplasia due to 21-hydroxylase deficiency. And as I've already mentioned, sex assignment and ambiguous genitalia is a big part of that problem. A lot of people that are intersex over the years and centuries really in our societies have actually integrated with society fairly well. And it's actually in recent times, particularly interaction with the modern healthcare system, that we had a lot of problems. There was sort of a dark period in the 1970s in which the medicalization of intersex people led to a lot of difficult problems for these people. There was concepts of concealing the diagnosis for these people throughout their childhood and even into their adulthood, so that the only people who knew what was actually happening with their bodies were their doctors and their parents. People had sometimes unnecessary and certainly non-consensual surgery as children, and sometimes these surgeries led to infertility, certainly lots of difficulty with external genitalia and sometimes even internal organs surgically removed or changed, and leading to loss of sexual sensation and function. So a sort of dark period in the medicalization of these peoples that we are fortunately in modern times moving away from, although not completely, and there still remains controversies with respects to care of intersex people. All of this is to be in contrast to gender identity, which really is about understanding that it's not just biological determinants in terms of how we define our gender, but there's also a social construction element as well. And by social construction, we're talking about the influence of our culture, however that's defined. But what does the culture allow and even explicitly and sometimes implicitly exclude in terms of what is normal with respects to behavior, roles, and relationships that are allowed? And this is varied in different regions of the world. And in certain regions of the world, like the Netherlands and New Zealand, there are fairly high rates. One in 100 people or more could be coming out as transgender. Whereas in the United Kingdom and some parts of the world that have sort of colonial connections to them, we can see the rates are much lower. And in the US, the rates are 0.6% and vary depending on the region of the United States. Here you can see varied percentage of prevalence. And when you look at this map, I look at the map anyway, and it sort of maps along with the electoral college Republican Democrat divide that we were all sort of subjected to in the last 3 months going through the election there. And not surprising, because there's probably a fair amount of overlap between acceptance and non-acceptance based on regions and based on some of the cultural norms associated with people's religious identities and so forth. But before we spend a lot of time pointing to our neighbors of the South and criticizing, I will say here in Canada, we have even lower rates based on the 2019 census, 0.35% for people who feel comfortable coming out as transgender. So what is it about our society that makes it difficult for people who are transgender to feel that they can come out and be accepted by our society? Well, there's a lot of things. Transgender in comparison to cisgender people were looked at in a Stats Canada survey, and you can see here people that are trans report lots of unwanted behaviors that they are exposed to, both in public as well as on online persona, in terms of unwanted comments about their sex or gender, unwanted comments about their sexual orientation, unwanted sexual attention, and even unwanted physical contact. You can see here in comparison to cisgender people, transgender people have statistically significant increases in many of these categories, both in real life, in the real world, but as well as on the online world as well, leading to many of them feeling they have to take protective measures to protect their identity, particularly in the online environment. Transpulse Canada analyzed and continues to analyze a lot of data in the trans community. And you can see here that 43% of trans people identify as having struggled with mental illness in comparison to 20% of the general population. This is, of course, outside of the numbers we're probably going to see that are even higher in the context of the pandemic. 1 in 3 people that are trans on this survey stated that they had considered suicide over the past year. That's in sharp contrast to the 2.5% of the general population. 5% of people that are trans attempted suicide over the past year in this survey in terms of self-reporting, which is in comparison to into the general population, it's obviously much lower than that. There's about a 3% lifetime general population attempt at suicide. This expands in their day-to-day lives outside of the realm of mental illness and suicidality. 15% report having not enough food to eat, and despite having fairly high and even higher rates in the general population of secondary education, 50% report having a wage that is below or at or below the poverty line, or living in low household incomes, and being experienced to various measures of abuse, as we'd already alluded to in the other StatsCan survey, both verbal, physical, and sexual harassment. Transpulse did a survey as recently as last month, and we can see here the demographics of people that are trans. Much of people are younger. We see that there isn't as much in the older ages for whatever reason, and probably some of this is in relation to lifespan, in relation to mental illness and suicidality. We can see here the demographics fairly high in terms of education, and yet this is not materializing in terms of opportunity, in terms of employment. There's a fair amount of salaries that are at or below the poverty line, and a fair amount of high frequency of people being in low income housing. I'm not even expressing data here about homelessness as well. So you can see that the day-to-day life that somebody is experiencing in our culturally constructed society for trans people is difficult for many of them, as they both self-report to Stats Canada and Transpulse. And then when you expand that to not just the day-to-day life, but also to the greater sort of culture that we experience in the media, both online but other media, you can see here there are many other messages that people that are trans receive that are sort of against them. This is some of you might have known about this controversy involving J.K. Rowling the world famous children's author of the Harry Potter series. J.K. Rowling has a net worth close to being more than half a billionaire, but is not transgender and certainly not a content expert on anything on healthcare wise. She's a children's author, but for some reason felt the need to weigh in on the trans community. And you can see here, these are some of the posts that she first did on Twitter that put her put her in opposition to many of the trans activist movements. And you can see in many of her her direct quotes here, you can see sort of classic use of implicit discriminatory tropes. I have many trans friends. While I respect trans people, at the same time, this is about me and about my cisgender status as a woman. And so the trans activist community called out J.K. Rowling, as they do many individuals, as being what they call a TERF, or a trans exclusionary radical feminism. And for those of you who don't understand critical theory, what they're using in the term radical is they're talking about the sense of someone being an identity advocate for their own identity. In this case, J.K. Rowling is being an advocate, obviously, for cisgender females, to the exclusion of trans people, in particular, to the exclusion of trans women. All this is to sort of illustrate the concept of intersectionality, which some people might have heard and not fully understand. Intersectionality was first coined by Kimberly Crenshaw in the 1990s as a concept to explain the negative synergy that can exist when one has more than one status that you can be discriminated against. For example, if you were both a woman but a person of color, in particular, the data she was looking at was for Black women. And this well explained some of the issues they had with respects to affirmative action policies, having a real hole with respects to helping people of color, particularly women people of color. Affirmative action policies were helping white women, they were helping Black men, but Black women were not being hired or promoted to the same degree. And it was understood that there was this sort of double discrimination that was happening, and that was a useful concept to use. But more recently, this concept of intersectionality seems to be increasingly co-opted into sort of a hierarchical categorization of various ways in which someone could be discriminated against, whether it's due to their racial or ethnic status, whether it's due to their sexual orientation, their biological gender, their gender identity, their socioeconomic status, religious status. So if all of these features are immutable characteristics of individuals in which it would be a human rights violation to speak against, this is, it's hard to know arbitrarily why one thing is over another. And in the end, looking at it this way, for the most part, results in people just sort of pointing fingers at each other in the same way that the categorization of TERF versus, let's say, the trans community has happened. But this is happening not just in these situations. I mean, this concept of tribalism, I see all the time here. I don't know this individual, but this came along in my Twitter feed. Twitter is a great platform for sort of inducing all of us to be a little bit more tribal. It's probably a completely useless platform, actually. But anyway, here you can see somebody just notes that although they are a person of color, they were being excluded. They felt they were being excluded based on the basis of white privilege, and at an actual talk for EDI. And so again, I'm not sure that Kimberly Crenshaw thought that intersectionality should have been used in this way. And I think when it's used in this way, it becomes more toxic and less useful. I think we can't in Canada talk about the culture versus the trans community without talking about Jordan Peterson. For those of you who don't know him, Dr. Jordan Peterson was an obscure clinical psychologist from the University of Toronto, who in October of 2016 really rose to fame or infamy, whatever you want to call it, at that time, basically doing protests against trans people, particularly in using pronouns. Peterson denied being transphobic at the time and stated that he was simply against compelled speech as defined by Bill 16, a federal law, which he stated that forcing people to accept concepts of gender identity and expression and in particular, to compel them to speak to it, was equivalent to a totalitarian state and comparable to Nazism, Maoist China, and in particular, Stalinist Russia. This notoriety propelled Peterson to a bestseller status for his book, 12 Rules for Life. And this was his sort of treatise on taking responsibility in life was the key to finding meaning. And he subsequently was tapped because of this book and this fame and notoriety to write the foreword for the 50th anniversary of Solzhenitsyn's Gulag Archipelago. From 2018 to 19, Peterson went on a worldwide tour capitalizing on his book and his rise to fame at the expense of the trans community, and during which he began using benzodiazepines and started advocating with his daughter, Michaelia, seen in this picture, for a strict diet of just beef, salt, and water. Peterson felt that was a successful strategy to combat autoimmunity, the mechanism he believed was the cause of his many ailments, including his depression. It should be noted again that Peterson is a clinical academic psychologist. In 2020, during a global pandemic and worldwide social protest in response to the killing of George Floyd, as well as the political upheaval during Trump's re-election campaign and his subsequent sedition of insurrection, Peterson, the self-styled champion of responsibility and meaning and crusader against Russian-style totalitarianism, lost trust in his Canadian healthcare providers and had himself transferred to a Russian hospital where he was subsequently intubated and treated with propofol to detox from benzodiazepines. To this day, he continues to recover back in Canada in relative obscurity. So trans people are subjected to their day-to-day existence as well as into the media of being subjected to a lot of difficulty with discrimination. But this unfortunately also exists in our healthcare systems. US surveys have found that 1/3 of people have had negative experiences being transgender involved with their healthcare providers. And in Canada, 45% report having their healthcare needs being unmet, even though most of them, an even greater relation to the general population, actually have a primary care provider. 12% report actually avoiding going to the emergency department for emergent conditions because they feel that they would be treated negatively in the emergency department. So we are not, the healthcare community is not exclusionary to the systems that these people face, both in their day-to-day lives and in the culture and the media that is around them. I'm going to, from that point, allow Dr. Massarella to take over.
Thank you, Dr. Harper. It's always a bit cautionary when you're talking about a subject in which you're part of the actual community in which the subject is on. But I think it's certainly worthwhile knowing a little bit about when transgender people access the healthcare system. Because I think that's where most of the people in the Department of Medicine will come into contact with transgender patients, isn't in directly treating transgender patients with regards to their actual hormone treatment specifically, but rather seen in a setting in the context of being part of the healthcare system. And certainly, you know, from my clinic, which we have over 1,000 transgender patients in my clinic, you know, I certainly hear stories consistently about difficulties that people have with the healthcare system. And there's another paper that people can access that we wrote in 2015 in the Annals of Emergency Medicine, which is open source, around avoidance of emergency department visits in Ontario by transgender patients. So the term, you know, one often sees the term, you know, LGBTQ, LGBTQ2S, and there's sort of much longer terms. I think in the context of, if you want to use, probably the term that's most commonly used right now in our society is LGBTQ2S. And although probably most people are aware of what those terms are, it's lesbian, gay, bisexual, transgender, queer, and then two-spirited. And two-spirited, of course, is unique to our Indigenous population and can only be used by Indigenous people, and it's certainly worthwhile knowing that. With respect to terms that we use, certainly as Dr. Harper mentioned earlier, trans female and trans male are two terms that are used quite commonly. The other terms that we use are trans woman and trans man. And then again, this phenomenon that we've seen really in the last 10 years. I mean, when I first started doing this work, I virtually saw no patients who identified as gender non-binary. But certainly in the last 4 or 5 years, we're certainly seeing a lot more people who are presenting as gender non-binary. And these are essentially people who may not identify with any gender specifically, or may feel themselves that they may identify more on the masculine side of the spectrum or the more feminine side of the spectrum, but aren't specifically identifying within the gender binary. With regards to medical treatment, that can be quite complex with gender non-binary people, but overall, we are definitely seeing an increase in gender non-binary people. If I could also comment once briefly about one of Dr. Harper's slides, where we talked about incidents. One of the difficulties when you survey marginalized populations or hidden populations is actually accurately identifying all people who present in that category. But just to give you some context, even if we were to use the 0.35% of Canadians who identify as transgender on a national survey, that would still be approximately, I did just some quick calculations, about 129,500 people in the country. And if you look at Ontario, it's about 40%, that would still be 51,800 people, which again, if you put that into practical context, that would be about 25 to 30 full-time family practices just devoted to seeing transgender people. That just gives you an idea that it's not it's something that is quite significant. And then finally, looking at two-spirited people. If I could have the next slide, Will, that would be great. I don't know so the other thing that people often talk about and can get quite upset about is language. And I think we should all remember that the English language is a living language and evolves constantly. I mean, within the last 20 years, if we'd asked ourselves in 2000, were we familiar with the term selfie, emoji, things like LOL, we would say no. And so certainly the English language evolves. And so the fact that we're seeing different terms as applied to gender, I don't think should be surprising. And all I would argue again is that when we use respectful pronouns for people, two things happen. One, it respects their identity. And secondly, it makes them more likely to access healthcare. So there are very often situations where I have patients who I send to other consultants or specialists. And when it comes back, because their legal ID may not match their gender identity, gender expression, I get a consult letter that, first of all, dead names the patient. And when we say dead naming, that's using the name that they were assigned at birth, but may not be the name they use now, which can be quite harmful or hurtful to a transgender person. And secondly, using male or female pronouns, when clearly I know that that patient is presenting in a gender expression way as a female or a male opposite to what their birth certificate or their OHIP card may indicate. So again, these things, although they may seem trivial to the person writing the letter, are things that contribute to transgender people not actually accessing the healthcare system and having worse health outcomes. And so again, all I would argue is that it's respectful to use a person's preferred names and pronoun. And I think that overall, if we do that, we will see patients who will be happy to access the healthcare system as it exists today. And again, one of the things that we can look at from a systems perspective is we can create charts and medical records that allow for people using their preferred names and preferred identities. And it should be noted, if you actually look at the St. Joe's dovetail, we actually do have a section in the dovetail that allows for recognition of people's gender identity. So I think that's a very useful thing. And whenever you're building in an EMR, certainly for our colleagues at the HHS, it's something that you should definitely be aware of and something that you should think about as you're building your EPIC EMR. Can I have the next slide, please, Will? Thank you. So again, I'd like to touch on the idea of transition. So transition is a process by which somebody transitions from what their natal or assigned gender at birth to how they may, to their identity that, their gender identity, gender expression that they see themselves. And it's a multifaceted process that's just beyond just prescribing hormones. So again, it's very, it's quite straightforward actually to provide, to prescribe transgender hormones. I think Dr. Harper will touch on that shortly. But we have to think about transgender people in terms of whole person healthcare. And in a sense, transgender people are unique within the LGBTQ2S community because, being a gay or lesbian or bisexual, although there is a coming out process and there's absolute marginalization that occurs for LGBT youth and adults, in essence, nothing really changes in terms of your presentation. There's no specific medical intervention. But when you look at trans people, there is medical intervention and there is, significant change associated with somebody presenting in their gender identity or gender expression. And so we do have to remember that trans people beyond hormones also do things such as voice therapy, their deportment, how they present, things like other surgeries, including facial feminization surgery, which is surgery that you undergo to feminize your facial features specifically. There are gender surgeries for trans males. There are top surgeries, which is not just mastectomy, but also includes something called chest contouring. There are considerations such as legal name and ID change, birth certificate change, interacting with family, friends, and colleagues. And I can certainly say from a personal experience, I did this at St. Joe's about 11, 12 years ago now. And that all I can say was an interesting experience. And certainly from my colleagues who are on the call today from St. Joe's, I think who were around at that time, they probably do remember to some extent that process. But one thing I would say overall is I did have tremendous support from my hospital and from my colleagues. And certainly I'm forever grateful for that. But these are important things to remember when we're seeing these clients or patients, is that this is a whole person, whole transition type process. And again, as I stated earlier, the visibility of coming out is unlike any other, is unlike LGBT patients. So something that we should be aware of. Next slide, please, Will, if you don't mind. Thank you. So finally, from my perspective, the other thing I'd like to talk about is, why are transgender people less likely to access healthcare? Why do they have negative healthcare experiences? So again, one thing that we should remember as providers is we can be the most wonderful, positive ally that's possible. I mean, you could be attending pride marches, you could, have the transgender flag in your Facebook or Twitter space, and which is great and it's fantastic. But when your patients come to the office, it's not just you they're seeing your whole office. So if they go into the front door and they're met by maybe a receptionist or a nurse or a resident or somebody else who's working with you in that clinic, and they misgender the person, or they use language that maybe is not considered appropriate, then that essentially reflects on your clinic. But secondly, also again means that patient may be less likely to come and access your clinic. So when I talk about a positive space, and when we talk about positive spaces, what we're referring to is literally from the minute you enter the door to the minute you exit the door in your clinic. And so again, when you're thinking about seeing transgender clients in a healthcare context, we should understand that it really is a whole person, whole team process. So one of the things that I think would be helpful, and I think one of the things, again, as a department that we should think about, is that any member, certainly newer members, and it would, I've done this training, I think a number of us have done this training, but anybody that enters the department, we should consider having positive space training and anti-oppression, anti-racism for members that sign up, and really training for all staff. And finally, a couple of things I'd like to point out. When Dr. Harper was talking about J.K. Rowling, interestingly enough, she doubled down with her new adult book, which describes a murderer as a transgender person is the actual killer. So there you go. But bathrooms. One of the things I never thought I would spend a lot of time talking about are bathrooms. But I always like to talk about bathrooms in some sense. I always ask people, what is the reason that you use the bathroom? And most people say, well, because I need to go. I think it's exactly the same for transgender people. The reason they use the bathroom is because, believe it or not, they actually have to go to the bathroom. I think that's something that's very important to remember. And so when we look at bathrooms again, although in smaller clinics, most of your bathrooms will be single space, we would advocate for bathrooms that are accessible to all people, and again, not for bathrooms that are specifically gendered. And that's something, again, just to think about, because even when you say, oh, you can use the a specific bathroom that's non-gendered, and you still have male and female bathrooms, in a sense, then you're still singling out transgender people and other folks when you do this. So those are things that I just want people in the department to think about when they think about accessing healthcare for transgender people, and how we might make our entire healthcare system more friendly, so that when transgender people present to our institutions, to our hospitals, to our clinics, that we have a welcoming environment that recognizes their gender identity and gender expression. Sorry, thank you.
Thank you, Dr. Massarella. So there's a changing paradigm. The changing paradigm with respect to gender identity is really looking at it as a state of being and no longer considered a disorder. Back when I was training, the DSM-4 labeled people who are transgender as having an identity disorder, gender identity disorder. And 10 years later, the DSM-5 updated this to gender dysphoria, which was defined as sort of a feeling of discomfort or distress from their identity and or body characteristics being different from their natally assigned sex at birth. But the WHO, in terms of its upgrade to ICD 10 to 11, is now removing transgender as a mental health disorder, moving it into a new chapter, a sexual health chapter. And I think increasingly WPATH, and I know myself, I look at the Endocrine Society, in present day, we would really be moving towards this concept of it not being a disorder or even necessarily a dysphoria, it's just gender incongruence, and that you can potentially remove the need for a patient to have to be distressed to receive gender-affirming care. And this sort of changes everything. Like the previous model was a psychiatric-based model in which the psychologist or psychiatrist would function essentially as a gatekeeper, requiring some form of psychiatric label before an endocrinologist such as myself could even begin initiating gender-affirming hormonal therapy or even consider referring for gender-affirming surgery. And so this is sort of like a red model because of a lot of stop signs. Whereas a more modern day informed consent model would involve the concept of the patient, like in any other healthcare setting, being provided information, the pros and cons of the various treatments. And oftentimes, because there's still not a lot of disseminated knowledge and experience as we're talking to today, even just the basic terminology, many times patients know more or are more knowledgeable than their healthcare providers. And this is part of the struggles they have in terms of accessing care with their primary care physician or in emergency situations, as Dr. Massarella alluded to. So if you can take this concept of informed consent and move it even into a primary care model where the family physician who knows the patient best and can help guide the patient's journey could refer to an endocrinologist if necessary, but wouldn't necessarily be shackled in terms of beginning interventions as they were necessary in the context of hormones in particular, and at some point gender-affirming surgery. So talking about hormones, so obviously hormone therapy for trans women would include estrogen, and most of the time this would be oral or transdermal, and increasingly people are looking at potential for injectable as well. Sometimes involves anti-androgens such as spironolactone, proterone acetate, sometimes less so finasteride and LHRH agonists. Trans women don't usually need progesterone unless it's in the context of and the anti-androgen proterone acetate. And it's important to note, while there's no randomized clinical trials for the effectiveness of these regimens, there are certainly guidelines. I tend to look at Endocrine Society and WPATH guidelines, but here in Canada and in Ontario, there are great national guidelines that Dr. Fung demonstrated to us last month at the Endocrine Citywide Rounds. So the changes a person can expect to see in response to such hormonal therapy, a trans woman, are both irreversible and reversible. There are some reversible skin changes, muscle mass changes that could be reversed, but there are irreversible changes such as chest growth, and then various other body changes that will happen that could be reversible or irreversible with hormonal therapy. The time set in terms of when the changes would be expected certainly can begin within the first few months, but sometimes take years before the irreversibility aspects and the final expectation of some of these changes would occur. Hormone therapy for trans women would have some contraindications and cautions. The absolute contraindications would be unstable coronary disease, estrogen-dependent cancer, end-stage liver disease, any kind of impaired capacity due to mental illness or otherwise, or instability in mental illness would also be a relative contraindication as well, because such hormonal therapy and the transition it would induce could exacerbate those things. Not necessarily a contraindication, but something to be cautious about would be people who have stable coronary disease or stroke, venous thromboembolism, family history of venous thromboembolism, and in particular in combination with smoking or significant hepatic dysfunction, poorly controlled metabolic conditions such as hypertension, dyslipidemia, diabetes should be adequately controlled, because they can sometimes be exacerbated by the initiation of some of these hormonal therapies, and then seizure disorders, which particularly can be affected by hormones. Hormone therapy for trans men predominantly is testosterone, which is usually given injectable or transdermally. There aren't really biologically orally activated hormones that are potent enough, to be frank, for even cisgender men. I hardly ever use oral. The problem with oral testosterone is it's toxic to the liver, and the only formulation that doesn't go through the liver just doesn't really have much biological activity. Even my cisgender men don't seem to find it's adequate enough, and certainly anyone trying to transition to be a trans man doesn't have active components as well. Similarly, there are both irreversible and reversible changes: scalp hair loss, deepening of the voice in terms of laryngeal enlargement, facial and body hair, and enlargement of the clitoris, and vaginal atrophy are some of the irreversible changes. And I do note that some of these terms, you have to be careful if the particular person you're dealing with actually does have gender dysphoria. With the naming of these parts, you'd want to be careful about using the proper names that they would see fit, that wouldn't be triggering for them. Again, similarly, whether the conditions in response to hormonal therapies would induce reversible or irreversible changes, and the onset, and then the expectation, whether it's in the months or years for to see the maximal benefit over time, is varied for the various conditions and aspects of the phenotypic characteristics we're expecting. There are, again, contraindications and cautions for testosterone therapy for trans men. Pregnancy and breastfeeding, if is occurring, is an absolute contraindication. Again, unstable coronary disease, androgen-dependent cancer, impaired capacity, again, due to mental illness, would be contraindications, and then cautions in people who have more stable coronary disease, stroke, venous thromboembolism, polycythemia, significant liver failure, metabolic disturbances, and again, androgen-sensitive epilepsy. We know that hormones are thrombophilic, so one of the things to look at is venous thromboembolism and cardiovascular safety. There was a fairly recent database analysis looking at about 5,000 trans men and women, and compared to age-matched cisgender people, and specifically looking and tracking through ICD coding occurrence of venous thromboembolism, ischemic stroke, and MI. We can see here for trans women on estrogen and anti-androgen hormones, there are higher rates of venous thromboembolism in comparison to, for instance, cisgender males or cisgender females. Definitely higher rates of venous thromboembolism, higher rates also of stroke in comparison to cisgender men and women, and no real difference between MI, but a higher rate of MI compared to cisgender females, which is not surprising. We know that cisgender males also have higher rates of myocardial infarction. For trans men using testosterone treatment, there really were no significant differences in comparison to either cisgender men or cisgender females with respects to venous with respects to myocardial infarction or stroke. There was it was almost reaching significance in terms of venous thromboembolism, but no statistical significance. So some remaining areas of uncertainty in terms of medical decision for transgender involve a number of areas. One of them is fertility, and really just how to optimize options for people pre-transition. The issue really is timing. Many of these people that are young are not thinking about whether or not they eventually want to have kids. They're not in a relationship with anyone that they want to have kids at this point. It's the same decision that's faced by a young person who, for instance, is going through cancer and is going to go through a chemotherapy regimen that is going to unfortunately impact on their fertility. You know, whether to cryopreserve oocytes, sperm, or even consider IVF kind of procedures to actually cryopreserve embryos, which is actually much more effective than cryopreservation of gametes, is something that trans people have to face, and I have discussions with all my people prior to transition. Some of the other areas of uncertainty are the changing demographics, particularly in the pediatric population. This is a a bigger concern for my pediatric endocrinology colleagues. But one of the things to note is prior to 2009, Ken, when I was doing this work in the first decade of my practice, and certainly in training, there was an entirely different demographic with respect to the people being referred for transgender care to our clinics. Predominantly, they were natal males who had a strong history of childhood dysphoria. But now, over the last 10 years in particular, the phenotype has changed. There's been an increase in referrals of all categories, but the big category now that is actually dominating the referral practice is there's a lot more natal females who have little to no childhood dysphoria. And so it's uncertain. I mean, we don't know the reasons for these changes. Part of it may be the changing cultural norm. There's maybe greater acceptance, but there's not only an increase, but there's a change in the ratios of people. And in particular, there's a lot more young women natal wise that are being referred for transitioning to men. And so why is this occurring, and what are the implications? Some of the implications that I know we think about is there, just from a statistical analysis perspective, a greater probability of potential overdiagnosis or overtreatment? And then when we talked about intersectionality, what does this mean with respects to potentially cisgender gay women versus the intersection of the trans man? I know for myself personally, I'm trying to incorporate more of an affirmation model along the lines of gender incongruence without necessarily requiring dysphoria. But one of the things to note is, in the absence of diagnostic criteria, whether we talk about DSM or ICD, how is a clinician to be certain, right? There's no confirmatory blood or imaging testing here. And some of the treatments, hormones and surgery, do have side effects, some of which are irreversible. So you do have to spend some amount of time, thinking about these cases and making sure you're doing the best decision and not doing any harm. And we also have to understand, if we're going to take the psychiatric component out of the model, we still have to remember that mental illness, if it's causing mental illness instability or an impacting on capacity, that this is still going to be a relative contraindication to gender-affirming treatments, and that you need to be sure that you've got things in place to protect your patients during transition. And not being a mental health expert, I have to figure out how to do that if we're not working through a model in which there's this sort of gatekeeper role for psychiatry or psychology to begin with. I think one of the increasing challenges I have now is I'm seeing a lot more people present now that are pre-transition, but they're also pre-social transition. They haven't changed socially in their community, but yet they're wanting trials of hormones. And so it's challenging for me because there's no longer a mental health expert who's probing questions of gender dysphoria, gender identity, and mental illness stability. And so I'm forced to ask some of these questions to make sure, is this the right decision? But I want to be careful on how I make these questions and these probes to not, appear transphobic myself. I'm simply trying to ascertain what's happening for the of conversion therapy is found to be both illegal in Ontario and in Canada, as well as a human rights violation. Conversion therapy classically has been used to describe attempts to change someone's sexual orientation to heterosexual, knowing that this is completely ineffective. Both sexual orientation and gender identity, for that matter, are hardwired, and certainly the attempts to do so causes distress, mental illness, and even increased suicidality, and is, as I said, illegal and a human rights violation. The trans community sees attempts to change people's gender identity as a conversion therapy against gender identity. This has led to, we talked about activism against people such as J.K. Rowling and Jordan Peterson, but there's also been activism directed against healthcare scientists. I think it's been a wake-up call during the pandemic. A lot of our colleagues and scientists have not been used to working in contentious environments, and many I know have been surprised at there's been various activisms directed against, recommendations with respect to COVID, for instance. But those of us who work in transgender care are aware of these things happening, and in particular in relation to this changing demographic. There was a Dr. Lisa Littman in Brown University who published a controversial paper in 2018 suggesting that these changing demographics might be due to a social contagion, which she used and termed rapid onset gender dysphoria. At the time, this was very upsetting to the trans community, who felt that this was really a transphobic way to look at what was probably happening in society, on the basis of society being potentially less transphobic. And certainly there were clear methodology questions with respect to Dr. Littman's paper. In particular, most of the inquiries were with respect to just parent interviews, no interviews of the actual people themselves. And so the effects of activism here for Dr. Littman was that she had a post-publication review and had to rewrite her paper. Her own university retracted support for her in this work. But, at the end of the day, I think reasonable people can argue on these kinds of scientific questions, even controversial questions. But we want to be careful that we don't necessarily eliminate some of these inquiries, which are just legitimate inquiries as to, what is happening and trying to investigate what's happening. Similarly, and more closer to home, Dr. Kenneth Zucker, a psychologist and expert in not only in gender identity for many years, but also intersex since the mid-1970s, was working at CAMH and was actually the founder of the gender identity clinic there. For almost 3 or 4 decades, he treated 500 prepubertal gender variant children, promoting an approach which he would have described as trying to get these children to accept their natal gender assignment, at least until a point where these children were old enough to reach an age of maturity where they could make a determination of their gender identity themselves. This is, for those of us, again, in the endocrinology field, see this as a sort of approach to intersex people, trying not to induce treatments and surgeries on children that are still forming their identities, because the intersex population had been so harmed by an approach where a lot of decisions were being made for them. Dr. Zucker applied an intersex approach to gender identity and transgender peoples, which the trans activist community accused him of being guilty of conversion therapy. And after an external review, CAMH agreed and closed the clinic and fired Dr. Zucker in 2015. Dr. Zucker ended up suing CAMH, and a settlement was reached in 2018 between CAMH and Dr. Zucker, but that clinic has remained closed. And that approach, again, I think reasonable people could argue the pros and cons of an approach like this, and certainly the cons have been a legitimate concern about this being conversion disorder, and it potentially, for transgender people, this approach activating mental distress and even suicidality. So I think I want to end there. We've left some time for questions, and I know that Dr. Massarella and I can certainly answer some of the questions that have been put in the Q&A, and I think Mark is going to moderate for us on that regard.
Yeah, thanks, guys. That was a great presentation, and certainly the lived experience is helpful. There were a couple of questions which we answered, I answered, or Karis answered, and typed in the one. One was an anonymous comment that you might want to look at, Will, because it was directed specifically at you. Okay. With respect to the public questions, from Stephen Hill, who's one of our biochemists. This is actually an interesting one. It's funny how these bring up questions you've never thought of. Laboratory reference intervals, how do you set them and how do you use them for this population?
Mark, if I could speak to that, I actually met with the director of lab medicine for Life Labs around this, then the VP medical, because I always had that question, because we use the reference ranges that are provided to us for, cisgender men and cisgender women. And it is difficult to know how to measure those levels and what they mean. So what we mostly go by is, I don't know, Dr. Harper, if you use the same, we mostly go by clinical effect. And we go by other potential adverse effects. So for example, with trans males, look at their LFTs, look at their hemoglobin, because all trans males will get secondary polycythemia to some extent. So we certainly look at all those levels, but it is, you're right, it is difficult to know how to interpret those levels. And I'd be interested to hear Dr. Harper's feelings about that as well, because it's certainly something that we've struggled with over the years.
Yeah, I mean, I agree, and I think that at the end of the day, some of the struggle is looking at hormonal levels, both in the context of cisgender, but transgender, but also even age. I mean, like the truth is, I don't even think we know how to define a testosterone. What's normal for a 20-year-old, 60-year-old? In the cisgender population, I have people, and even within those ranges, the ranges are super wide. And then I have people coming in, cisgender males, for instance, coming in saying, "Hey, I'm older now, and I feel tired. I don't have the sexual function I had from decades ago, and my testosterone seems to be in the low range of normal." And so I think we need to do a lot better job of studying this and defining what is normal, both in the cisgender and in the transgender populations, and recognize that there's just a range here, and there's not a strict sort of like positive negative. It's not like a D dimer for venous thromboembolism. Mark knows more about that than I do.
Probably not a great example, because the D dimer
Yeah.
is a problematic test at the best of time itself, as Karis would know.
I just had that problem yesterday.
Yeah, nothing is perfect.
We're going to run out of time for questions here. There's quite a few questions, but I'll pick and choose some. So Henry Dungu, who's a good friend of mine and is an associate member of the department who lives and works in Uganda, asked the question, in this global village, I imagine we have transgender people in sub-Saharan Africa. Do you have any data on the prevalence of sub-Saharan Africa? And how do you think you could be facing the challenges of care for the transgender community in Africa and elsewhere? There's, I think, pretty wide, we're having this as a grand rounds discussion today, which means that it's something that people are comfortable discussing. I'm sure that that's not the case in some countries. And Karis, you probably spent a lot of time thinking about this, so maybe you can provide some comments on that question.
Well, I think, again, with marginalized hidden populations in certain countries, it's very difficult to measure numbers. But I think what we see consistently across the world, even with queer and gay folks, is that there is sort of an underlying sort of consistency around the world in terms of presentation or incidents. I think culture may predict who's actually willing to be out publicly, because we know, certainly our colleague from Uganda would agree that there have been untoward consequences for people of the LGBTQ community in Uganda who have been out. So I think if you really look at the numbers overall, I think what we could say with some certainty is that probably the rate of people who identify with gender dysphoria, gender incongruence, whatever term we want to use medically, it's probably somewhere between 0.5 and 1% overall. And then when you look at sort of LGBTQ populations in general, again, it's a bit of a wide variation, but about 4 to 8% of any population would identify with that characteristic. So I think those would be consistent, because human beings are human beings, but again, I think cultural issues as it relates to the acceptability of those identities will dictate to some extent what the overall incidence you might see in any particular country. So I would be pretty confident that everywhere in the world there are transgender folks. It's just a question of how they can express themselves.
Thanks very much.
Yeah.
We should probably, what I'm going to do is I'm going to copy all the questions, or I have copied all the questions, and I'll post them, both Karis and Will. Perhaps they can just answer back directly, since we are effectively out of time. I just, one last announcement is that, and related to this talk, Sonia Nand, who I see is on watching, had circulated our second Department of Medicine Equity, Diversity, and Inclusiveness survey, and we've sent out 2 reminders about it. And I would encourage everyone to please complete that. It will help us to better understand some of these issues in the Department of Medicine. And it also allows us to do some, I think, really good science on these issues. This will be the second of the survey, so we will actually be able to compare results from the first to the second. We've had pretty good survey return now. We're up pushing 50%, which is great for a survey, but we'd like to get it up to significantly higher than that. I think, Will, do you want to make any comments on that, just to sort of hopefully reaffirm the importance of people completing that survey?
Yeah, I mean, it's important. We're trying to tie this survey to the efforts we're making. We know that some people are happy with the efforts we're making, some people are not happy, and it's a work in progress. And how do we know without asking you? So people who are wondering how they can help, a big way you can help is just get your survey done, and I can tell you that's going to be making a big difference, because it's going to guide us to speak from a place that the right answers can emerge, not top down heavy sort of, we'll tell you what it is. It's like, tell us how you feel about this. Tell us what you need, and we can try to make a more accurate change that's going to help everyone.
Great. I'd like to thank Dr. Massarella and Dr. Harper for a great talk today. The next Chairs Grand Rounds will be a month from now. The next Grand Rounds will be for both hospital corporations next week. I hope everybody has a great day, and we will see you next time. These will be available on our YouTube channel within the next couple of days. So if you have people who are interested in seeing these, I would encourage them to just type Department of Medicine channel in YouTube, in Google, and you'll be taken to the link and you can watch these again. Thanks so much, everybody. Thanks, Dr. Massarella, Dr. Harper.
Thank you.